Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to dive into a topic I've been covering for a long time. That's EHR and EHR consulting and really optimization now of EHR, adoption of EHR, and really how it's been impacted by COVID-19. And our guest today is Justin Diehl. He's vice president of Epic Services at CereCore. Welcome, Justin.
Thank you. It's a pleasure to be here.
Yeah, so before we get into the meat of how COVID-19's impacted EHR, tell us a little bit about yourself and CereCore.
Yeah, sounds great. So as you mentioned, I'm Justin Diehl. I am the VP of Epic for CereCore. Prior to joining CereCore, I actually worked for Epic, the vendor. And then after that, I did strategic consulting for leadership for healthcare organizations across the US. I'm going through many different initiatives. CereCore is focused on helping healthcare technology needs and really striving to use our operator heritage to use best practices and drive it forward.
Awesome. Well, I think we know EHR is the core of every healthcare organization today, so it's such an important topic for everyone. So, I think it's interesting. We have to talk about COVID-19 these days, it seems. So, what are some of the changes that you saw healthcare organizations make to their EHR for COVID-19?
Yeah, the changes, there was a large breadth of them across the board. The biggest thing is the healthcare EHRs had to be nimble enough to respond to what was happening in each of the markets. And as most people know, COVID was very different in areas, right? Some were at capacity, overwhelmed sites. Others were, not able to keep enough staff on site. And then the other extreme, of course, was having too many staff and not enough patients because people were not going into the clinic, not going to hospitals, but they didn't have a large outbreak in that area. So a couple things that had to be done were you had to create new screening tools for patients, since most organizations had processes to ensure that they were keeping their staff and other patients safe. We had to create new labs, order sets, because a new virus, new needs there. And then, of course, new and virtual departments, because those organizations that were at capacity or overflowing had to be able to adjust or nimble and move patients in different units, different areas, and really be able to respond to those needs for it. The other thing that's attached to that is analytics became critical and important throughout this whole ordeal. We not only had to report internally and then consolidate against all of our healthcare organizations, we had to do it nationally at state level, local governments, all across. We get an idea of what the scope and magnitude of what was happening was. So that required a lot of quick development, quick pivoting, and more importantly, community standards for individuals or hospitals to follow, so the data coming across was uniform and something that could actually be used as we worked through it. When we looked at that patient population or those hospitals where staff were overtaxed and overburdened, we found that a lot of changes had to be done with user roles and templates because traditional roles were changing. We took the concept of practice to the top of your licensure more serious than ever when you have to put a surge of users into organizations. Even to the point that some organizations requested that if they had clinical staff working in their IT departments or other ancillary departments that still had their licensure, they were asking them to come back in and volunteer to do clinical work just to help take care of the patient population in need. So not only do we have new user templates for clinical users, now we have a lot more hybrid roles where you're a builder, but now you're also a clinician and you're actively, in some cases, doing both at the same time because of the urgency and the needs. One that's pretty big is telehealth. I think you got a lot of adoption and we'll say street credit with COVID because people weren't going in and had to. And not only that, the government actually started doing reimbursement and making it more of a feasible program. So a lot had to be turned around there, and quicker than many of us would have thought or wanted. And one, we turned around a full telehealth program in under a week for Epic sites, which a normal project plan, 3 months if you're being aggressive, 6 to 9 if you're, being cautious and following through it. So the cut time there has been phenomenal with that. And there's just so much stuff that we're seeing, the mobility and user devices, another big area to look at. With people not wanting to share or touch surfaces, more stuff was getting pushed to what can you do on your personal phones, so you're not sharing it with other clinicians or patients, what can you do on tablets, and really developing those strategies around driving those forward.
Let's talk about, I mean, that's interesting what you said, because we saw that, right? The telehealth implementation went from a 3 to 6 month, and let's be honest, it's often a year or 18 months, depending on, really corporate bureaucracies as much as need of timeline, right? It got compressed to a week. I mean, what does that, is there a lesson there for us that we need to learn, that it's like, not everything has to take 6 months to a year to implement in our organization, but we can do it more quickly? Or do you think we won't learn from it, and just the crisis necessitated it?
I think it's all about balance moving forward. It showed us that we can do it and we can do it successfully by reducing some of the bureaucracy and red tape. And I think that's going to be a lasting change from COVID. That's going to be one of those positive changes, right? Oftentimes there's a perception that healthcare IT is where good ideas go to die because of the bureaucracy and how long it takes, right? I'm a clinician, I submit something that I really want. 6 months later, I hear that's getting evaluated. A year and a half later, it's finally getting implemented, and I forgot I asked for something by that point in time. And this is really showing that we can be a strong partner, we can pivot to big needs and make things happen with it. And I think organizations will need to look at their processes and say, okay, what can we reduce based on what we learned from COVID? And maybe 1 week is too short because you want to have more testing and thorough, but
Sure, of course.
maybe 2 months is more accurate as opposed to that 6 months or 12 to 18 months, however it goes based on those processes.
Yeah, I mean, I think we all agree a week wasn't ideal either, but it was a little fast. I think your comments about community support are really interesting though too, because that's the other positive I've seen from it, is how many competitive organizations we even finally said, okay, we can work together. And I'm hoping that that opens some doors that says, you know what, we are competitive in the marketplace, but hey, as healthcare IT professionals, we can collaborate on a lot of things, especially when it's in the best interest of patients. So yeah, that's another one I'm interested in. I also thought it was interesting, the Epic Deterioration Index that got a lot of publication and coverage, which, it was not intended for COVID, but pivoted to that, so lots of interesting collaborations that happened with it. But are there some changes to the EHR during COVID-19 that really are going to have a lasting impact, and maybe for good or for bad, that maybe it was rushed too much and so it's going to have a bad impact, or maybe that, like, oh, we made something more efficient because of it?
Yeah, I think we touched on a couple of them in the previous question, but I think, telehealth is not going away, and switching to a less overall travel model for everyone is going to happen, right? The patients, the providers, technology specialists, all of that is going to do more remote stuff. And I think we're going to see more adoption of tools in the home than we've ever seen before, and integration with tools so the patient doesn't actually need to go in anymore for it, and the data is being collected and streamlined and used appropriately. You really added to it with that community feeling side of things. I think the notion that we all have to work together and we're all in this to do the right thing for the population as a whole is going to stick. And population health will get more important as we roll through it. And government's going to help ensure that that happens if we do try to revert back to our old ways of siloing some of our data from it. The other big one, is I think the mobility tools and stuff, watching some of the vendors and partners increase during COVID, their development to meet needs rapidly has been impressive. We talk about healthcare, how our change control process can take a long time. We see the same thing on the vendor side when we put in a request for an enhancement or an opportunity. And I think they've also learned that they can pivot and respond very quickly to some of these things. And I think it might have changed some of their roadmaps or overall strategies and probably shortened them significantly, which I think is going to help. And all vendors are being forced to play, because one of the big problems that we've seen pre-COVID is maybe Epic is doing great with mobile development, but then some of the third-party systems we interact with are not doing so great. So now a nurse or a physician, yeah, they can do their Epic work on their smartphone or tablet, but then they still have to go back to the computer to look at EKG results or do other things. And being able to put that all together and have all the vendors working on the same mission or development or direction is really going to last and stick with the EHRs and non-EHRs, quite frankly.
Yeah,
There.
and I think we have seen the development just increase. It's amazing what they were able to push out given the circumstances, and there's a lesson learned for vendors for sure. Are there areas of the EHR that kind of were exposed, if you will, that like, oh, these weren't ready for COVID-19, and are there things that EHR vendors really need to do to prepare for, we're going to have future crises, whether it's more COVID or whether it's something else. What are there areas you saw that you're like, yeah, EHR vendors need to spend some more focus on this?
The biggest one for me was interoperability across the board. All of them are working on it or say that they're working on it, but COVID really brought to light, right? You had one EHR that might be taking the lab or collecting it, and then it might be getting sent to a different hospital because that's where they're resulting it or doing that because they want to keep things controlled, and they might be on a completely different EHR, and then it has to come back to the original EHR, maybe go somewhere else, it's another EHR, and finding out that interoperability may not have been as strong as some vendors promoted, and cause some duplicative work or inefficiencies to happen. So it goes back to that, playing nice and realizing that we're all in this together and we need to work it out. Now, I get it, just like everyone does. There are strategic business reasons why you want to be the best and withhold some stuff, but we need to get over some of those perceptions and ideas and do what's best for the community as a whole. So interoperability was probably the number one thing. Number two is really analytics. A lot of the EHRs have gone great strides for analytics, but really only in the way that if all of your data is contained within their EHR. So we take a customer or a healthcare organization that has multiple EHRs or multiple systems, and that data becomes very hard to mine through, pull what you need to, and create usable reports in a time of a pandemic or a need. Because each one has different data points or data elements, and then how they integrate together plays. So again, it's all about that standardization and interoperability.
Yeah, I think it's a really salient point with the interoperability, and not just the two systems being able to connect, but what data should be shared. I think we're also learning a lot, especially from a public health perspective and assessment. So, hopefully we see some progress there. A lot of people have been calling for it for years. So, like you said, there's competing interest, business interest there. So hopefully it can be overcome, and from the crisis and the experience there. What's been the impact on COVID-19 to the consulting business? Obviously, CereCore does a lot of EHR consulting. You already mentioned. I think you're not traveling as much, right? Consultants are probably going to do it remote. We're going to find some equilibrium. But are there other impacts that you've seen?
Yeah, I think the biggest thing is it's forcing flexibility to a degree that hasn't necessarily existed before. And when I say that, each organization is very different through COVID. As I mentioned, some are overwhelmed with COVID patients. Others were in areas that weren't hit so hard, so they were prepping because they felt the surge was going to come, but maybe wasn't. So what those two organizations needed was very different. And then everybody was hit financially by COVID, so they're looking to reduce costs or change. So there was a lot of delaying, postponing projects, and taking a strong look at the portfolio, which in some situations meant consultants who were engaged got removed from projects, and then there wasn't necessarily another project for them to go to because all healthcare organizations were in the same boat with that one. So I think what happens there is it's changing the model or the paradigm. So you're not on a set contract, right? It's a consultant that you have for 6 months, 40 hours a week to do X work. It's coming in and being a strong partner and saying, if you need somebody for 10 hours, we have that resource for you. We will give you 10 hours, no long-term commitment, no contract. That'll help you manage your budget, but also hit those high priority things that you need to tackle and take out. I think most organizations should be able to do that. Since consultants were, removed from projects, you probably have people sitting on the bench who can either not be working, or you can use to help the community and, reduce and pivot to flexible schedules, and really do some good in the industry. And that's really what we strive to do with CereCore, was say, we understand we're in a different world. We are going to pivot, adjust, or do whatever is necessary. And I think we talked about what's going to carry post-COVID, and I think that's one of them. I think healthcare organizations are going to see, hey, there is a solution in play where we can dictate our needs and we can be very specific about it, and we can be granular, and reduce our costs and get the most bang for our buck, right? Use the consultants for things that are action needed for consultants as opposed to finding 40 hours of work for them to do on a project where they could be doing things that they don't necessarily need to
Gotcha.
with it. We've talked about the traveling side of things. I think the adoption of the remote workforce is a big one. Prior, organizations were looking to reduce travel just to save costs. Now they were pushed into it and actually see how successful individuals can be from working from home, both consulting and their own staff. It'll be interesting to see what organizations do with space post-COVID and how many actually just embrace the remote workforce.
Yeah. No, I think that's interesting, and I don't know. I was thinking about it from a recruiter perspective. Is it make it easier if they can all work remote, or do the consultants love traveling and they're going to miss it and they're going to miss their status? That's going to be a fascinating look at from the recruiter side. But it is kind of scary to me from a EHR optimization or EHR implementation side, because obviously those projects had a purpose, or at least you would hope they would have a purpose, and now they've been delayed. Is it really just gonna, is it gonna have bigger impacts, or is it really just kind of, let's be honest, more burnout for the physicians who didn't get their projects implemented because they were too busy with COVID? They couldn't, optimize the EHR and make it more efficient for them. What do you see that impact having these delays?
That's an interesting question and a tough one to answer, because I think it depends how well the organizations reprioritize and scope their initiative. If it was an organization that was very reactive and just tabled a bunch of stuff without thoroughly examining what the long-term impacts are, and just picked the highest hour items or what they thought were the most costly items and took on the plate, then they probably will see stuff, right? They will fall behind, they will struggle, they'll need to either do a surge of resources once COVID's over and they're in a better position, or do something major to catch back up. But if the organization, took a little bit of time, reacted well, looked at the portfolio and said, okay, here are the critical things that are necessary to our values, our mission statement, our strategic plan. We need to keep these moving forward, but here are things that we can move back with little impact or little damage. Those are the organizations that won't see much. They'll catch up without any sort of problem. My fear right now is most reacted by gut because we haven't had time to thoroughly think through things and analyze it. So it's going to be more that former one, which will cause some lasting problems that'll take a while to get out of. And it's going to take a partnership between all sides, right? The healthcare organizations, consulting companies, the vendors, to dig everyone out, knowing that everybody's going to be in a slightly different place with it as we go through it.
Yeah, and if I look forward, I think that discussion is going to continue for a long time to come. Just looking at the financial position and having to get rid of elective procedures, et cetera, right, has impacted so many healthcare organizations. That discussion that you talked about is something that is going to be ongoing. But what do you see for the next couple of years for EHR projects at healthcare organizations and really the EHR consulting business as a whole?
Yeah, I think the next few years is going to be interesting tale for a couple. And on the last question, the only thing I'll add to, because you brought up a good point there at the end, I think one thing that's going to be a struggle moving forward is trust. And what I mean by that is in healthcare IT specifically, and maybe healthcare as a whole, there's been such a trust that healthcare is always going to be needed and jobs are always secure and you have nothing to worry about. And then hit COVID, which is the first time that many individuals had seen furloughs go on across the board. It's the first time that really any of us had the experience of my job might be in danger, and it may not be as secure as I want it to be. So getting back out of COVID and saying things can happen and things can pivot, it's going to be interesting to see how we all respond to that new fear in the back of our minds that's come out of this. That COVID PTSD, so to speak, with it. In some organizations I have to give a lot of credit to. They've done a great job of communicating and handling that very well, that the impacts might be minimal, but it still is an all-encompassing type of thing. Now to your most recent question, I think, we dove into a number of these things. I think it's going to continue to be a focus on mobility, telehealth. We'll need, that technology developed for the patient's home. I think there'll be more integration that we've not even considered or thought of, to the point that more people used online grocery shopping or delivery services to take care of what they need. Having partnerships between healthcare organizations and those services will allow providers to get data and track, what is the household ordering, what types of things are they consuming, and really give good real-time information to a dietitian to help put some good outcomes forward, or help to be able to track that in a way that hasn't been done before. And that's just one example. There's many different areas where you look how mobile and we've become with it, and how that can integrate into your overall patient health journey. And I think we're going to see a lot of those types of things. Those creative solutions come where all of these vendors saying, hey, we could partner here and help your patients. And I think many people will support that integration if it helps hold them accountable and drive better health forward for them. Because everybody wants that, especially when COVID happens and you see a lot of people not doing well in health. It becomes top of mind with that. So I see those things really going forward. And then, of course, I brought this up several times, but I think we really need to look at healthcare more universally and improve the flow of data between organizations, between individuals, but just between everyone.
Well, I hope you're right. I think those are the areas that have been exposed by COVID: interoperability, the health disparities, et cetera. So hopefully it is a call for action in everyone in healthcare. I think we're all suffering from a bit of PTSD, as you kind of described it, and probably will for many months to come. But as we come out of it, hopefully we can use this as a positive learning experience and improve the healthcare experience. So thanks so much, Justin, and thanks everyone for watching this interview. If you want to check out more great healthcare IT content like this, check it out at healthcareittoday.com. Thanks, Justin.
Thank you. Appreciate it.